અને so that તમારા બધાનો attention આવે, so the most beautiful lady on the world નો હું ફોટો પહેલે ચાલુ કરીશ. We all know her. She is Mona Lisa and her real name was Lisa. The surname is this. Now why did I put it over here in a lecture of lipidology? Because she had xanthelasma and she had xanthoma. So the cholesterol levels in her and her family were high, and she actually died because of atherosclerotic heart disease. Some other cholesterol findings in physical examination would be, as I said, xanthomas and xanthelasma. We all know why do we need to focus on lipidology, because the high cholesterol level is associated with coronary artery disease beyond doubt. The problem is the confusion. Lot of guidelines, lot of data, and there is no uniformity. There were many guidelines, but the most extensive and well documented guidelines were the 2018 ACC/AHA guidelines. And after that, I think there is a lot of uniformity. So I think we will discuss how to treat a case of dyslipidemia according to the guidelines. So first of all, the screening. When do you do your first lipid profile? So there is this ATP3 guideline which said that it should be done at the age of 20. But this is too aggressive. So normally we follow what is the United States Preventive Service Task Force recommendation that all male more than 35 and all female more than 45 should have their lipid profile screened. Fasting lipid profile for aged 35 plus and 45 plus is a must. Now in some patients, you can screen before, that is men between 20 to 35 and women between 20 to 45 if they have diabetes, hypertension, heavy smoking history and a family history of cardiovascular disease. You can do it prior also. So this is whom to screen. Now once you have your lipid profile results, what should you follow? You should follow the 2018 ACC/AHA guidelines. So when you see the guideline, it is very confusing. You'll see a lot of this kind of charts which actually confuses us all. But ultimately I would give you the gist of the guideline. This guideline says that there are only 4 classes of patients. Majority of our patients, 80 to 85% of our patients would fall into these 4 classes for whom cholesterol treatment with statin is recommended. The first and the most important class is individuals with established ASCVD. Now what is ASCVD? Is atherosclerotic cardiovascular disease. So any patient who has established ASCVD, for example history of heart attack in the past, becomes established ASCVD and he needs to be on statin. The second group is individuals aged between 40 and 75 with an LDL cholesterol of more than 190. LDL cholesterol level more than 190, 40 and 75 years. The third group is diabetic people, the aged between 40 and 75. Mind you, right now the guidelines are not clear if the patient is less than 40 years or more than 75 years, but between 40 and 75 years, and if the patient is diabetic, you need statins. And the fourth one is individuals with a predicted 10-year ASCVD event risk of more than 7.5%. Now, how do you calculate this? There's a calculation. So we will keep into mind this 4 categories of patients. Now let us start with the first case. So this gentleman is a 58-year-old gentleman, known case of hypertension, non-diabetic, non-smoker, had a minor stroke 3 years back, and his total cholesterol is 182, LDL is 92, and HDL is 38. How do you manage his lipids? So first question, as we saw the categories, the first question that I would ask is, does my patient have ASCVD? Yes, because he had stroke. So my patient is ASCVD and therefore I need to treat him with statins, no questions asked. So the answer is yes, we start statin. Now what is the target? So coming back to what is ASCVD, history of MI, ACS, stable, unstable angina, stroke, other arterial revascularization and peripheral arterial disease. So these patients, because he has a history of ASCVD, he should be treated with statin. Now they are further classified into very high risk ASCVD and stable ASCVD, because that would give us the target of LDL. Whether we should get the LDL to 70 and below or we are happy with 100 and below. So how are they classified? The very high risk ASCVDs are MI within 1 year. So MI, stroke or symptomatic peripheral arterial disease within 1 year is major. And the other high risk features are past history of bypass, angioplasty, diabetic, hypertension, CKD, heavy smoking history, and LDL more than 100 on therapy. So if you have very high risk, that is 2 or more major, or 1 major plus 2 or more high risk condition. Otherwise, they are stable ASCVD. So when the patient is very high risk, your target of LDL should be less than 70 and in some even less than 50. But if your patient is stable ASCVD, I would be happy with a LDL level of less than 100. As I said, the guidelines are for patients between 40 to 75. So whenever it is less than 75, you should start high intensity statin. Now what is high intensity statin? High intensity statin means lipid profile reduction, LDL reduction by more than 50%. That is achieved by a dose of 40 milligram atorvastatin or 20 milligram rosuvastatin. And if the patients are more than 75, you should go with moderate intensity. So as I said, high intensity, your target should be lowered by more than 50% from baseline. And that is by 40 or 80 of atorva and 20 or 40 of rosuva. Moderate intensity statin would be 10 or 20 of atorva. This category of very low intensity statin is practically not used. It is only used for patients who cannot tolerate high intensity or moderate intensity. So guidelines are very clear that these are not to be used unless the patient is not tolerating the moderate or high intensity statins. So now coming to case 2. 54-year-old male with diabetes and hypertension. He had CAD more than 3 years. So again, more than 3 years back. Atorvastatin 40 milligram is what he is on and other medications. And his LDL is 120. Are we happy? We are not happy. So what is your advice regarding the lipid treatment? High LDL despite statin. So our target should be to get it down further. So we have to add ezetimibe. Nowadays a new molecule bempedoic acid is also available. So we can add. And if not controlled, we should then add PCSK9 inhibitors. That is inclisiran. Now case 3. 52-year-old male, routine health checkup, no diabetes, no hypertension, non-smoker, and for the first time his LDL is 240. How do you manage this lipids? So again we go to ask our questions. Does my patient have ASCVD? No, he does not have, because no past history, no diabetes, no hypertension. So now let us go to question 2. What is the LDL level? LDL level is 240. Anything more than 190, hands down, no questions asked, start treating the patient. So in this patient, it has severe primary hypercholesterolemia, LDL more than 190. So no need for any other questions and immediately start high intensity statin. Again, lifestyle changes, everything to be emphasized. Case 4. 60-year-old male with diabetes and hypertension. So we have risk factor, diabetes. Non-smoking, pressures are normal, lipid levels are 92. How do you manage? So again, we ask the 3 questions. Does the patient have ASCVD? No. Is the LDL more than 190? No. But the patient is diabetic. Does the patient have diabetic and age more than 40? Yes. So he should be on therapy. Now there is a bit of confusion here because there are 2 guidelines. So there is no doubt that we should start statin. How? So there are 2 guidelines. One is the ACC-AHA, American College of Cardiology, and another is ADA, Diabetic Association. They differ slightly. In the age criteria. ACC says 40 to 75 and ADA says anyone more than 40. Any diabetic more than 40 should be prescribed statins. And they also differ on how to decide on the type of statins. For example, ACC, I will put the chart. So what does the ADA say? Anyone more than 40 and diabetic, if the risk is high, that is 10-year ASCVD more than 20% and multiple risk factor, go for high intensity statin. Otherwise, only moderate intensity statin. Now, what does the ACC-AHA say? 40 to 45, multiple risk factor, high intensity, otherwise moderate intensity statin. So this is a slight difference, nothing significant, but we can say that any diabetic more than 40 years of age should be on moderate intensity statin, right? Now coming to the question that if the patient is diabetic but less than 40, or if the patient is diabetic and more than 75, what is to be done? So here the guidelines are different. The ACCHA says that you should assess other risk factors. For example, is the LDL more than 160? Is there family history of premature ASCVD? Is there elevated CRP levels? What is the ABPI index? And what is the calcium score on the CT scan? So if any of this is positive, then less than 40 diabetic should be, otherwise he may not be on statin. Very clear. Case 5. 58-year-old non-diabetic, non-hypertensive, non-smoker, and the LDL level is 123. How would you approach? So again we ask the 4 questions. Is there ASCVD? No. Is the LDL more than 190? No. Is he diabetic and age more than 40? No. So the age is between 40 and 45. What is the 10-year ASCVD risk? It can be easily calculated from the Google. If anyone wants to try, they can do it on their phone. So when you say ASCVD calculator, they will ask to put in certain demographic data like what is the age, what is the smoking, or what is diabetic status, and then they would give you a 10-year risk. So for example, this gentleman has a 10-year risk of 10.8%. So it is not more than 20. And therefore, whenever it is more than 20%, you should start high intensity statin. But this gentleman does not fall into that risk category, and therefore you have to then evaluate whether he has any other risk enhancers. And these risk enhancers are LDL more than 160, which he was not because he was 132, CKD, family history of premature ASCVD, and persistently increased triglyceride. So we will not go into the details of this. If this gentleman does not have any risk enhancers and the patient is very apprehensive, कि sir मुझे लेना चाहिए कि नहीं लेना चाहिए, you can ask for him to get a CT coronary calcium score. If the calcium score is more than 100, statin is recommended in this patient. If the calcium score is less than 100, no statin is required, right? So in this case, the 10-year risk is 10.8%, so you need to assess for risk enhancer, and if there is no risk enhancer, you can just advise lifestyle changes and you may not give him statin therapy. So I think I'll go with the last case because there is 7 minutes left. 34-year-old healthy lady, no family history of ASCVD. The total cholesterol is high, 212, and the LDL is also high, 140, but not definitely more than 190 or 160. She is concerned about her LDL levels. There are apprehensive patients which we see in our OPD daily who says कि cholesterol 200 ऊपर થઈ ગયું साहब કંઈક करो. And then what is your advice? So again we go back to our 4 questions. Does she have ASCVD? No. Is her LDL more than 190? No. Is she diabetic with an age more than 40? No. Is her age between 40 to 75? Yes. So, no. So she does not fall into any of the high risk patients. And in these kind of patients, in the age group of 20 to 39, the risk calculation is not studied. So we just advise lifestyle changes and consider statin only if LDL is more than 160. Only in her case it was 140, so it is not more than 160. And if there is family history of premature ASCVD, yani her brother, her father, her mother had a young coronary event, again, still this is not a very strong indicator. If she is very apprehensive, we should ask a coronary calcium CT score, and if the CT score is less than 100, we can reassure her that she may not take statins. I think so. With this, I have broadly discussed how do we approach. I would not take the SGPT high and muscle this thing. I will just go to my recommendations. So I'll go to my summary. So the summary is, so statins for all patients of ASCVD, you classify them into very high risk or stable ASCVD and target your LDL levels to 100 or 70. Statins for all patients with an LDL more than 190, and these both group would receive high intensity statin therapy, that is 40 or 80 of Atorva and 20 or 40 of Rozua. The other group is diabetic patient with age more than 40, generally use moderate intensity statin, but if there are additional risk factors or the ASCVD risk as we calculated from Google is more than 20, you go with high intensity therapy. For non-diabetic patients between the age of 40 and 75, do the risk calculation. If it is more than 20%, high intensity. If it is between 7.5 to 20%, look for risk enhancer. If there are any risk enhancer, give them moderate intensity. If there are no risk enhancers, do not give them any statin. And the last, for age less than 40, there are no clear-cut guidelines. So statin only if LDL is more than 160, or there is family history of premature ASCVD, or the calcium score is more than 100. So with this, I think I conclude. I open the session for questions.
Sarak,